Today's outline in the next 15 minutes, I hope to be able to discuss with you a few important points. The first is to talk about why kidney transplantation is the preferred treatment option for our patients with kidney disease. Then specifically, I'd like to talk about why living kidney donor transplantation is the preferred option between living and deceased donor transplantation. I'll briefly touch on outcomes of our kidney transplant recipients, as well as some key principles of living kidney donation, outcomes and risks for our living kidney donors, and then finally, the reason we're here today is to touch on disparities in access in living donor kidney transplantation. So to start, what is very clear now is that kidney transplantation is the best treatment option for our patients with kidney failure. This slide here is a figure from one of the landmark studies from the 1990s that showed this. And what these researchers did is they compared patients who got a transplant as compared to those who remained on chronic dialysis therapy. And what they were able to show is that patients who got a transplant lived longer. On the bottom part of the screen is better survival. On the top part of the screen is worse survival. And transplantation is represented by this dark line, and you can see that over time, and in fact very quickly after transplant, at approximately 3 months after transplantation, those who received a transplant had better life expectancy as compared to those who remained on dialysis. Not only is there an increased life expectancy with a kidney transplant as compared to staying on dialysis for those eligible for a transplant, but there's also the aspect that transplantation provides an improved quality of life. This is because of freedom from dialysis, but also freedom from dietary restrictions that come with being on dialysis, the freedom to travel, and for certain individuals, the freedom to have a pregnancy that may be less complicated than one on dialysis. And for several, transplantation allows for potential for return to the workforce. On this slide, you can see the proportion of transplants that happen from deceased donors and living donors at our institution. This mirrors very much the Canadian experience. And you can see that 54% of patients at our institution receive a kidney from a deceased donor and 46% from a living donor. But in fact, living donor transplantation has been going on for a very long time. On this slide, you can see that this is the first successful living donor transplant that ever took place in 1954 in Boston. Ronald Herrick donated his kidney to his identical twin brother, Richard Herrick, and this was pioneered by Dr. Murray and Dr. Merrill. And this transplant actually lasted 8 years, and this was the beginning of living donor transplantation. At our institution, we've been in existence since 1969. We've done over 1,500 living donor kidney transplants since the inception of the program. We receive about 400 to 500 referrals per year, and we do about 70 kidney transplants per year from living donors. And we are the largest living kidney donation program in the country. And the reason that we are all here and that we are all promoting living donor kidney transplantation is because it has several advantages over the alternative of deceased donor kidney transplantation. The first is it allows people to have the best chance of what we call long-term dialysis-free survival, so the likelihood of being alive with a kidney transplant that is functioning. For those who receive a kidney from a living donor, 50% of patients will have a kidney that is still working after 18 to 20 years at our institution, as compared to those who receive a kidney from a deceased donor, 50% of them will have a kidney that is still working 14 to 15 years after the transplant. So there's a significant difference in longevity of the kidney transplant. The second advantage of living kidney donor transplantation is that there's the opportunity to not wait on dialysis for an organ. So you can either decrease your time on dialysis or avoid it altogether in what we call a preemptive kidney transplant. And as a result, avoid all of the potential consequences that may ensue from being on dialysis. We also know that recipients who receive a kidney from a living donor stay in hospital for a shorter period of time. And also they have lower rates of delayed graft function, which is a condition where the kidney does not work right away. And finally, surgery can be scheduled electively at a time that is convenient for both donor and recipient and avoids transplantation that occurs kind of on off hours or in an unscheduled way. So these are the many advantages of living kidney donor transplantation. This is a graph that really just shows us how our transplant recipients do as compared to those who receive a kidney from a living donor versus those who receive a kidney from a deceased donor. And this graph just shows you what we call total graft survival, so the probability of being alive with a kidney transplant that is working. The red bars represent those who receive a kidney from a living donor. The blue bars represent those who receive a kidney from a deceased donor. And on the x-axis, you can see these are years after transplantation. What you can see is consistently over time, those who receive a kidney from a living donor have a higher probability of being alive with a kidney that is working as compared to those who receive a kidney from a deceased donor. At 10 years, that probability is 73% for a recipient from a living donor as compared to 63% for a recipient from a deceased donor. So clear advantage in terms of longevity, both for patient and the kidney. We also know is not only are kidney transplants from living donors beneficial to individuals, but they are beneficial to the whole population of patients with kidney failure. So if a patient receives a kidney from a living donor, what happens is they get removed from the waiting list for a deceased donor. And so as a result, the number of patients on that deceased donor kidney transplant waiting list decreases. And so therefore, the pool of kidneys available for those patients who don't have a living donor or their donor has been found to be ineligible increases. And as a result, the waiting time decreases all around. We also know that living donor kidney transplantation is beneficial for the healthcare system as well. There's significant cost savings that come with transplant, but in particular with living donor transplantation, given the opportunity to avoid dialysis and all of its associated health costs. So definitely advantages from a living donor perspective for both the patient, the population of those with kidney disease as a whole, and the healthcare system. Despite all of the advantages, we do know that in the Canadian context, living donation has plateaued. This is a graph showing the number of transplants from deceased donors versus living donors over time in Canada. The dark line here represents kidney transplants from deceased donors, the dashed line representing transplants from living donors. You can see that the transplants from deceased donors have continued to increase over time. Those from living donors have plateaued over time, despite all of the benefits. And that's why we're here today, to really try to tackle this issue, knowing that we want to make this preferred therapy available for all those that need it. Some of the key principles that we adhere to when we evaluate somebody that comes forward as a living donor to donate to their loved one, friend, family, or even anonymously, is that living kidney donors undergo a rigorous evaluation selection process, and that's because the safety of the donor is paramount, and that is a key principle in our program. The objective of the evaluation for a patient who comes forward as a living donor is to assess the risk to that person in an individualized way, using all of the components of their health history, their family history, and their investigations, and we select those who are at low risk. And finally, another important central component of the evaluation is that donation must be voluntary and altruistic, and it cannot be due to undue pressure, either medical or psychosocial, or any sort of coercion, and that's a critical part of the evaluation process that we evaluate very seriously. Now, you can imagine that not everybody who comes forward as a living kidney donor ultimately donates. And in fact, in our program, for every 5 people that come forward, only 1 goes on to become a kidney donor. And that's because for some, they have medical issues that prevent them from safely donating a kidney. And for many, medical issues are actually identified during the evaluation process. And so for what that means is that for many recipients or potential recipients that have kidney failure, they may need to have more than 1 donor evaluated prior to finding a living kidney donor that would be suitable for them. This is just a snapshot of what the evaluation process looks like in our center as well as many other centers. Over time, there are multiple steps in the evaluation process, but usually most of our patients start with our first phase of laboratory testing, both blood and urine testing, to determine whether they can proceed to the next phase, which consists of social work evaluations, CT scans, x-rays, and cardiac testing where appropriate. You can see that along the way, at any point, people may become unsuitable to donate if certain conditions are detected. And at the final point, a nephrologist determines the suitability based on the individual risk of that person and determines whether they're suitable to donate, unsuitable to donate. In some circumstances, more testing is required. But ultimately, once somebody gets approved as a living kidney donor and goes on to donate, we are all very, of course, interested in what the outcomes of those patients are. The first thing to keep in mind is that living kidney donation is safe because of our rigorous living donor selection process. The reason that we put so much effort into evaluating our patients in such a rigorous way is to ensure that donation is safe, and we are committed to promoting living donation in a safe way. What we also know is that people can live a normal, healthy life with one kidney, and that the kidney that remains can compensate an increase in size for the one that is removed or donated, although not fully. It certainly has the ability to adapt over time. And we know that when well selected, the risks to donors are extraordinarily low. Not zero, but extraordinarily low. Now, donation surgery usually, length of hospital stay after donation surgery usually averages 3 to 5 days. And there are complications of surgery, although they are rare, less than 3%, and the vast majority are treatable. And those can include infection, by far the most common, as well as rare risks of blood clot, bleeding, and lung collapse, although we certainly can address all of those if they occur. But the vast majority of donors will leave hospital 3 to 5 days after surgery with no complications. Over the long term, our living donors can live very, very healthy lives. There is a slight increase in risk of developing high blood pressure after donation surgery, but we remind our donors, of course, that high blood pressure is treatable with medical therapy and lifestyle changes. There's also data that suggests that there's a slight increased risk of developing kidney failure in those who donate versus those who don't donate. This is a key question that many donors ask. But what's important to keep in mind here is that the risk or the probability of that happening is extraordinarily low, between 0.3 and 0.47%. And so that number is actually less than the kidney failure proportion in the general population. And to put it into a little bit of context, we do things in our everyday lives that actually exceed the risk of 0.3 to 0.47%. So for example, getting into our cars, driving to work every day, often can have a higher risk of dying from that activity as compared to the risk of kidney failure in the general population. So it's important to think of the context when looking at these risks, and that's why donation in a very well-selected individual is low risk, because the absolute probability of the event occurring is extraordinarily low. It's important to recognize that a key component of safe care for donors is long-term follow-up, ensuring that patients have regular contact with a healthcare practitioner to make sure that the complications that can occur from donation are monitored and treated as appropriate. When it comes to psychosocial outcomes, what we know is that donors may experience significant psychosocial benefits related to the altruistic act of improving the health and well-being of another person. When looking at all the studies together in a systematic review, it was found that psychosocial health of our donors either was unchanged or improved after donation surgery. Although some donors do experience some psychosocial difficulties like anxiety, depression, stress, or lower quality relationships, the occurrence of that is very low. And reassuringly, the studies that have looked at this issue found that less than 1%, so a fraction of people, regretted the decision to donate a kidney at all. Now, despite the benefit of living kidney donor transplantation, there are some disparities in access, and that's why we're here today to tackle those. Two that I'll touch on are disparities based on income, as well as disparities based on ethnicity. Now, on this slide, you can see this is an image from one of the widely quoted studies from the United States that was published several years ago, where they looked at donation rate per million population. And they looked at it based on income. And the income brackets are kind of represented by these dashed lines, with the lower income brackets here at the bottom, the higher income brackets of the individual in the solid lines. And what you can see here is that the donor rate is higher amongst those with higher income, suggesting a strong association of income with donation. And what you can also see is there's fluctuation over time in donation rates. And when donation rate is on the incline, it seems to rise kind of more in a more accelerated way amongst those of higher income as compared to those with lower income. And when you can see donation on the decline, it seems to affect those predominantly in the lower income brackets, which really suggests that financial implications of donation are a potential barrier to living kidney donor transplantation. The other area of disparities is based on ethnicity. This is again a figure from a large US study that looked at donation rates or living kidney donor transplantation rates based on ethnicity. And And you can see here that those of white ethnicity have a higher rate of living kidney donor transplantation as compared to those from ethnic minorities over time, and that's a consistent finding. We also know that that is true in the Canadian context. Work from our own researchers here, Dr. Mucci in the audience, showed that African, East, or South Asian Canadians are less likely to have a living donor identified at the time that they come forward to be assessed for a kidney transplant. We also know that they are less likely to have a living donor kidney transplant subsequently. So these are findings that are consistent in both the US and the Canadian populations. There are many researchers that have put their heads together to try to figure out why that would be. We know that there are some financial implications to living donation, and although there are reimbursement programs in place, they may not fully cover all of the direct and indirect costs that are associated with donation. Travel, lost wages, childcare, for example. We know that there may be some potential differences in penetrance of the initiatives to increase living donation across income and ethnic groups. So these initiatives can be awareness initiatives or educational initiatives. There may be lack of culturally targeted programs to enhance education and awareness across ethnic groups. We also know that there's disparities in health conditions across certain groups that may affect eligibility for donation. So for example, obesity, high blood pressure, diabetes tend to run or cluster more in certain ethnic groups than others. And so therefore, some donors may not be eligible for donation even if they do come forward wanting to donate. And of course, there may be some disparities in healthcare access, income, and education as well across ethnic groups. And that's really why we're here today, to try to tackle some of these issues. So I hope that at the end of these 15 minutes, I've been able to show you why kidney transplantation is a treatment of choice for our patients with kidney failure, and also why living donor kidney transplantation is preferred over deceased donor kidney transplantation. We know that in healthy, well-selected individuals, living kidney donation is safe with low risks, and that's because of our rigorous evaluation process, which is paramount to donor safety. I've also touched on some disparities in access to living donor kidney transplantation we'll be talking about more today, based on ethnicity, income, and socioeconomic status, and dedicated initiatives to promote the safe advancement of opportunities for living donor kidney transplants are essential, and the goal of our forum today. So with that, I'll end. Thank you very much for your attention.